A blessed evening to one and all. It's a great delight to welcome one and all to yet another session of Cardio-Obstetrics Master Classes, the 7th Cardio-Obstetrics Master Class with yet another complex case. And today we have cardiac sarcoidosis with arrhythmia in pregnancy. I now request Dr. Justin Paul, sir, the course director, to share a few words on Cardio-Obstetrics Master Class and today's session. So over to you, sir.
Good evening, dear friends. It gives me immense pleasure to welcome all of you for the next edition of the Cardio-Obstetrics Master Class. This session we are having once in 2 months. We started from the month of January 2023. This idea was to bring together the specialists involved in the care of a pregnant woman with the heart disease, like cardiologists, obstetricians, obstetric anesthetists, cardiac surgeons, pediatricians, neonatologists, clinical pharmacists, as the scenario it may be. Because as you know, India is a country which is advancing in healthcare, and as a result, the cardiac contribution to maternal mortality is always on the increase. So it's very important that we all work together to help these women with the heart disease go through pregnancy safely. So one of the attempts that we are focusing on to develop this field of cardio-obstetrics in India is having this cardio-obstetric master classes. Earlier, we have chosen all those complex cases which have been the increased predictor of heart disease mortality during pregnancy, identified as per the MPAC registry, like women with prosthetic heart valves, women with LV dysfunction and heart failure, women with pulmonary hypertension. We have discussed all these conditions. Today, we are having a presentation from Fernandez Hospital, Hyderabad, where they are presenting a case of complex case of cardiac sarcoidosis with cardiac arrhythmia in pregnancy. This is a very unique and rare heart disease during pregnancy. Not many cases have been reported. Less than 10 cases have been reported in the world literature. So this is the first case that is going to be reported. I'm sure Dr. Malini and Team Fernandez Hospital will be reporting this case in the literature. If that is the case, this will be the first case of cardiac sarcoidosis during pregnancy from India. So we are happy to welcome you, and we have a esteemed panel to discuss this great case with you. Dr. Annie, would you go ahead with the introduction of the panelists and speakers?
Yes, sir. So I'm happy to introduce the panelists for today's session. Dr. C. Narasimhan is a distinguished cardiologist and electrophysiologist with over 4 decades of experience, presently working as a consultant at AAG Hospital, Hyderabad. Sir is the head of the electrophysiology department and the president of Indian Society of Electrocardiography. Sir has had an illustrious academic career and has won several awards during his medical school days. And he has authored numerous research papers and has been a key speaker in various national and international conferences. He is a pioneer in the field of electrophysiology, dealing with atrial and ventricular fibrillations too. His commitment to cardiology and his remarkable contributions to electrophysiology are beyond words. So I would like to introduce Dr. Betsy Thomas, ma'am. She is the principal and the professor of OBG, Amala Institute of Medical Sciences, Thrissur. She was the organizing secretary of UA FOXI 2017, AKCOG 2018, past president of TOGS, and Madam had an outstanding academic excellence with won many awards, including the Sri Chitra Award. Dr. Deepak Padmanabhan, consultant electrophysiologist, Bangalore, fellow in EP and advanced adult cardiology, Mayo Clinic, USA, joint secretary, and he's an associated editor in Europace, emerging leader in EP at APHRS, emerging leader in healthcare and medicine, and he's interested in AI-assisted ECG, amyloid, inherited channelopathies, complex arrhythmia ablations, and electroporation. So coming to the presenter of today, Dr. Malini, ma'am. So she's a consultant, maternal fetal medicine, Fernandez Hospital, Hyderabad. and she's been dealing with high-risk pregnancies and perinatologies. She's a mentor of many students training fellows in maternal and fetal medicine. Her main areas of interest are cardio-obstetrics, preeclampsia, obstetric critical medicine, and focus on obstetric critical care. So I now hand over the session of today, cardiac sarcoidosis in pregnancy, to our moderator and our course director, Dr. Justin. So before that, I would request the audience to post your questions in the chat box. We'll be looking forward to answering your queries during the panel discussion, and we'll also be having a live Q&A session at the end. Over to you, sir.
Thank you, Annie, for introducing the elite speakers. Now, I think we'll ask Dr. Malini to present the case of cardiac sarcoidosis in pregnancy. During the presentation, we'll have 2 or 3 breaks, and there'll be audience poll as well. So you're welcome to join the poll, and we'll be discussing the poll answers as well. So please go ahead, Dr. Malini.
Sure, sir. I'll just start sharing my screen. Yeah, is the screen visible?
Yes.
Yeah. Thank you. Good evening, everyone. At the outset, I would like to thank Dr. Justin Paul and the Cardio-Obstetrics Master Class team, Dr. Annie as well, for giving us the opportunity to present this rare case of cardiac sarcoidosis who had ventricular tachyarrhythmias and subsequently who became pregnant. So she is Mrs. A 29-year-old. Both of them are IT professionals in a non-consanguineous marriage. They're married from 2018 and residing at about 200 kilometers from the hospital. So her medical history started a year after marriage in January 2019. So we are presenting a timeline of symptoms so that everybody will be able to follow and understand. Onset was insidious over a period of 3 months. She had started having bilateral knee joint and ankle joint pains. She met a local practitioner where she was diagnosed as a probable rheumatoid arthritis. She was treated with sulfasalazine, prednisolone, and hydroxychloroquine with only partial relief of her symptoms. In July 2019, she had a spontaneous conception, which ended in unfortunately in a missed miscarriage, for which a surgical evacuation was done. And again, in November the same year, she had a laparoscopic ovarian cyst removal. Her cardiac symptoms started in December 2019, where she had episodes of palpitations, lightheadedness, and shortness of breath. These episodes were self-limiting, did not have any precipitating factors. She was admitted into the medical ICU for observation. A 12-lead ECG showed a right ventricular outflow tract ventricular tachycardia, which was monomorphic, wide QRS complex tachycardia. An echocardiogram was basically normal with a normal ejection fraction and cardiac function. Her troponin levels were negative. Electrolytes and thyroid profile was normal. A Holter was done, which showed recurrent non-sustained VT episodes of less than 30 seconds. So with these investigations, a cardiac MRI was suggested, and it was done with a gadolinium contrast, which showed normal morphological and functional analysis, but subtle T1 hyperintensity and gadolinium enhancement in the right ventricular free wall and the left ventricular wall. And there was a late gadolinium enhancement at the right ventricular outflow tract. So the cardiologist opined it could be right ventricular outflow tract VT, idiopathic etiology, or query arrhythmogenic right ventricular cardiomyopathy. So she was started on a beta blocker, metoprolol 50 milligrams twice daily. Her palpitations were under control. She was hemodynamically stable. So she was discharged with an advice to undergo genetic testing for probable arrhythmogenic right ventricular cardiomyopathy, and also suggested to repeat the imaging after 3 months. She was continued on prednisolone, hydroxychloroquine for her presumed rheumatoid arthritis. Because of her recurrence of joint pains, she went to a rheumatologist in February 2020, where she was investigated with rheumatoid factor and anti-CCP, which were negative. Antinuclear antibodies were weak positive and complement levels were normal. So with the background of the ventricular tachycardia, which was controlled on metoprolol, and the cardiac imaging showing a late enhancement at the RVOT and an undifferentiated arthritis, she was suspected to have sarcoidosis and she was investigated further. So a chest X-ray was done to look at any hilar lymphadenopathy or any fibrotic bads in the lungs, but it was a normal study. And a limited PET CT of the chest was done, which showed diffuse tracer uptake in the entire left ventricular and right ventricular myocardium, probable inflammatory myocarditis, and there was no mediastinal lymph node uptake. An angiotensin converting enzyme level was done, which was raised. So these are all the summary of the investigations. So MRI of the heart, the rheumatology workup, the PET CT, and serum ACE angiotensin converting enzyme levels. So with these, a diagnosis of cardiac sarcoidosis was made. She was started on immunosuppressants, that is mycophenolate mofetil. Deflazacort, a steroid was added, and she was continued on metoprolol 50 milligrams twice daily for her arrhythmic episodes.
So now, thanks, Dr. Malini, for presenting. Dear friends, we had actually planned the lecture of Dr. Narasimhan. He'll be doing it in another 5-10 minutes. He is just on the way from the airport, almost reaching in 5 minutes. He'll be giving the lecture in 5 minutes. In the meanwhile, I'll ask Dr. Deepak. Dr. Deepak, you saw the case flow. Do you think we commonly underdiagnose or late diagnose sarcoidosis in our clinical practice? What will be the message that you would like to give the audience? Because you are treating a lot of cases of cardiac sarcoidosis. What could have been done a little earlier? Could this case have been diagnosed a bit earlier?
Thank you, sir. Really cool presentation. And we've had that discussion too. Can we just go back one slide? I think she had some very pertinent points that she brought out. So, ma'am, if that's okay. Yeah, just let it be. So let's start off, right? You have an MRI heart which has been pulled out. You have LGE at RVOT. You have gadolinium enhancement in the RV and the LV. So typically when you're looking at gadolinium uptake in both ventricles, as you said, biventricular arrhythmogenic cardiomyopathy is one possibility. The other possibility always, and is a big mimic that is there, is inflammatory cardiomyopathy, namely sarcoid. It is a very close mimic of ARVC, commonly will be undiagnosed or missed unless the PET CT is done. And that is what triggers off this entire sequence of events. The very fact that she has been so good in being able to take an MRI and not stop at that and actually go to the PET CT itself actually brings a lot of gravitas to this particular case and probably ended up making the diagnosis rather than missing it. So that is my first thing. If we are suspecting any cause of non-ischemic cardiomyopathy, unfortunately these days, the challenge is from the Pandora's box, we've got to figure out on the MRI what we have, on the PET what we have, what is your GLS trying to tell you, and finally, what does your genetics trying to tell you? The worry remains that there have been a case series reporting genetic cardiomyopathies being positive on PET. So when we look at this diagnosis, that diagnostic conundrum, having all the pieces of the puzzle is so important. That's where this case was extraordinarily good. That's where the differential factor being the serum AS levels that brought that out.
Dr. Deepak, I would like to interrupt you here and ask you some question. In 2019 January, this lady had joint pains, and then subsequently she had an RVOT VT. Yeah, January. Now, if somebody has a joint RVOT VT who also have a joint pain, joint involvement is very common in sarcoidosis. I think we should tend to suspect sarcoidosis that point itself, probably. Anyway, we'll move forward, and I'm sure Dr. Narasimhan will throw a lot of light on this. We'll go to the next slide. This lecture break will take a little later. Yes, Dr. Malini, please go ahead. We'll do this little later once Dr. Narasimhan joins.
Okay, shall I proceed with the case then?
Yeah, right. This is slide number 2. You can present.
Yeah, so She was diagnosed as cardiac sarcoidosis and put up on immunosuppressants, that is MMF, deflazacort, and metoprolol was continued. So subsequently, in October 2020, that is after 3 to 6 months of starting this treatment, PET CT was repeated to see a response to treatment, but it showed an increased uptake in the entire left ventricular myocardium compared to the previous scan. So MMF dose was increased, HCQS was continued, deflazacort was continued, and metoprolol also is continued. Subsequently, with the increase in the dosage of the immunosuppressants, she was symptomatically better in terms of her arthritis pains, and there was no subsequent recurrence of the ventricular tachycardia. But still, at this point of time, she was advised to defer pregnancy because she is on the MMF, which is a drug that is contraindicated in pregnancy, and her symptoms have just begun to come under remission. So in the subsequent year, between October 2020 and November 2021, she had been under regular follow-up with both the cardiologist and the rheumatologist. And by November 2021, she was asymptomatic. And as she was contemplating pregnancy, MMF was stopped, deflazacort dose was slowly reduced, tapered, and she was switched over to azathioprine. And 3 months later, again, a PET CT was repeated, which showed total metabolic resolution. ACE levels were normal. 7-day Holter was normal. She's completely asymptomatic, and hence even deflazacort, that is a steroid, and the metoprolol were also stopped. She was continued on HCQS, azathioprine, and she is given the green signal to go ahead and plan pregnancy.
We'll take a poll here. So right now, dear friends, as you can see that the drugs have been modified a little, and the disease also has been from flare to sort of going into remission. She is sort of being prepared for pregnancy. At this point of time, we would like to get the audience opinion on what do they really think. Can you launch the first poll? Sarcoidosis and pregnancy. What happens to pregnancy with sarcoidosis? Medgamy team, can you launch the poll? I request the audience to kindly cast your vote here. You can choose one of the 4 options. Are you able to? Yeah, I can see people voting. So we have given 4 options: no change at all, or during both postpartum period and antenatal period there is remission, or remission in the antenatal period and flare in the postnatal period, or remission in the postpartum period and flare in the antenatal period. So we'll wait for another 10 seconds. The audience are still voting. Yeah, now maybe you can stop the poll and show the results. Who would like to discuss this? Dr. Betsy or Dr. Would you like to discuss, Dr. Betsy?
Yes, sir. I will take up, sir. As you already mentioned, it's a very, very rare case. I think only 51% of them have got it right. So it is an apt case for discussion. So the answer is, this is a T helper 1 cell mediated disease. So as we know, the T helper 1 cells will get suppressed during pregnancy, or pregnancy as such is an immunosuppressant condition. So just like other immunologically mediated diseases like rheumatoid arthritis, multiple sclerosis, sarcoidosis also shows remission during pregnancy. Almost 65% of them will have remission, but definitely after delivery, all the features come back, like estrogen disappears, the cortisol, which is associated with pregnancy, disappears, even the helper cells will get activated. So they will have a flare in the postpartum period. So option 2 is right. More than 50% have answered it right, sir.
Thank you, Dr. Betsy. Shall we do the next poll also? The poll 2, can you launch? Medgamy team. Thank you, audience, for your participation. It's very encouraging to us. So many people of you have participated. Kindly, you can start voting. How can you monitor the disease activity of cardiac sarcoidosis? You can send messages by chat box also. The chat options are open. If you think you are not happy with the questions, feel free to send your chat. Yeah, around. Yeah, that's fine. I think half of the audience, I think we'll wait for another 5 minutes, 5 seconds. Some more are voting. Thank you, audience, for voting. Thank you so much. Yeah, now you can show the results. Dr. Betsy, would you like to discuss? No, Dr. Malini, would you like to discuss this? Or
Yes, sir. Sorry, I was muted. Yeah. So, monitoring of cardiac disease activity in pregnancy, outside of pregnancy, maybe all these options would be correct. But in pregnancy, ACE levels cannot be relied upon because they naturally increase in pregnancy. 2D echo, yes, we can look at the cardiac function, but it would not give us the disease activity as such. Cardiac MRI with the gadolinium contrast. Gadolinium contrast, of late, the studies are encouraging, but it has been the belief that since it crosses the placenta and tends to concentrate in the fetal brain, it can cause fetal abnormalities. But the recent studies have been encouraging, and it has been suggested that with a multidisciplinary team consensus, if the test is required, then risk versus benefit, then we can go ahead with a cardiac MRI with a contrast. Even PET-CT, it has been shown that the fetal radiation exposure is quite less. Again, it is a multidisciplinary team judgment whether this mode of investigation is really required in pregnancy. If so, if it is life-saving for the mother to adjust the dosages and all, yes, it can be done with taking proper precautions to avoid all the fetal radiation exposure. And I would also request the cardiologist to give their inputs.
yeah, I request. I think, is there any enzymes that would help us, Dr. Deepak, at this point of time to monitor the disease activity during pregnancy? Maybe a quick answer from you. You are muted, Dr. Deepak. You are muted. You are
Sorry.
muted.
Yeah, sorry. I think, as ma'am said very well, you don't get any of these to monitor disease activity. It's a challenge. And therefore, there is this enzyme called chitotriosidase, localizes within the mast cells. The activity of that enzyme can be correlated to disease activity. It's still in its early phase of clinical use. We are still figuring it out how to kind of assess and understand the various fluctuations in that enzyme activity. But over a period of time, I imagine that that would be your safest way to figure out, because mast cells are going to be involved in the pathophysiology of the disease. And looking at the levels of that enzyme, which directly correlate to mast cell activity, you may have some benefit. But yes, there is no good gold standard at this point of time.
Okay, thanks, Dr. Deepak. Maybe I'll ask you a question. What will be the effect of, I think we discussed already the effect of pregnancy on sarcoidosis. We almost discussed how do we diagnose cardiac sarcoidosis during pregnancy. We again have some, what are the diagnostic? What are the high risk groups, subgroups, where you would like to advise avoid pregnancy in a particular patient with cardiac sarcoidosis when they come to you? Well, don't become pregnant. What are these patients?
Anybody with a low ejection fraction, mainly the cardiac reasons for avoiding pregnancy, someone who has a high pulmonary artery pressure, someone who has a low vital capacity. There, sir is also in there. Someone who may have a low ejection fraction to begin with, especially when they are poorly dehydrated. There is a lot of fluid overload. Especially on the 28th week, you can actually get into trouble. Patients with pre-existing devices, if present, within the ages of 40. High-risk pregnancies plus sarcoid, always a bad idea. Sir, what do you think, sir? Narasimhan, sir.
Oh, I think, sorry, first of all, for
thanks
joining
for
late.
joining us. Thank you so much. We have just gone through the 2 slides and 2 polls we have done.
Sure.
I think, thanks for joining. Kindly please give your comment on this one, sir. What patients you would like to advise to avoid pregnancy? Dr. Deepak has already said that low ejection fraction, low functional capacity, and severe pulmonary hypertension you will advise to avoid pregnancy. Would you like to add anything more here at this point of time?
So the main thing is there are patients who have what is known as refractory sarcoid with very frequent recurrence and relapses of their symptoms, and they are high-risk groups. If you have a combination of antiarrhythmic therapies and it was difficult to control VT, patient was having recurrent VT, shocks from the device, even pregnancy, before pregnancy, this was the course of event, and during pregnancy, it's going to become worse. And third is patients who have pulmonary vascular disease. Patients with cardiovascular sarcoid, some of them develop papillary muscle involvement, severe MR and PAH. The other group is a person with significant interstitial lung disease and PAH. Both of them will they fare badly during pregnancy.
Thank you, sir. Thank you so much. Doctor, I would like to ask the question to the obstetricians. What this patient abortions, if I'm right, or medical termination of pregnancy. What is? Can you comment on sarcoidosis and fertility, or incidence of abortions in patients with sarcoidosis?
Actually, sarcoidosis does not affect fertility as such. Maybe males suffer from a little bit of erection or erectile dysfunction. Otherwise, as such, female fertility is not affected. Though this particular patient had a miscarriage, usually sarcoidosis doesn't cause a miscarriage unless whatever Dr. Narasimhan and Dr. Deepak were mentioning, all high-risk patients, they are already hypoxic, cardiac failure, interstitial lung diseases. Such patients might have a risk. Otherwise, sarcoidosis, especially under remission, will not have any effect on pregnancy.
Thank you, ma'am. Narasimhan sir, is it okay for you to give your talk now?
By all means, by all means.
Please, sir, please, you can go ahead, sir. So now, dear friends, we'll have a talk on sarcoidosis, basic epidemiology and cardiac involvement. As you know, Narasimhan sir has been in the forefront of the country and in the world in terms of sarcoidosis. And sir has a very phenomenal experience in managing cardiac sarcoidosis. Over to you, sir.
Thank you very much. First of all, I would like to apologize to everyone for this delay in joining. This is not particular to pregnancy, but when are you going to suspect sarcoid in day-to-day practice? When a lady comes in with any gynec problem, that's what we are likely to see. So patients with cardiac sarcoid, in the olden days, if you had been in medical training, a patient comes with AV block, we just put a pacemaker and forget about it. What we have realized is at least 30% of this subset of patients have cardiac sarcoid and they present with unexplained AV block as the first manifestation. In a proportion of patients, their first manifestation of sarcoid can be sudden cardiac death, unexplained heart failure, recurrent ventricular arrhythmia, frequent PVCs as you saw in this patient. And a subset of patients increasingly we are seeing is patients get admitted with recurrent chest pain, mild troponin release, labeled as ischemia, but coronaries are relatively normal or minor disease. That's an ischemic mimic. So these are all the patients we see, and increasingly we see patients with unexplained valvular regurgitation as one of the manifestations of granulomatous disease, especially sarcoid. So asymptomatic AV block, monomorphic VT, a distinct entity you need to understand is called pleomorphic VT. That's why I was asking for the ECG. When you see the ECG pattern, it won't be a single morphology of PVC. There are multiple morphologies of PVCs in the same patient. And dilated cardiomyopathy, heart failure. This is an important subset because if you diagnose sarcoid, even in late cases, some of them you can avoid a transplant and terminal heart failure because it's reversible in the inflammatory phase of the disease. It can present as idiopathic left ventricular aneurysm. It can present with a misdiagnosed as ARVC. We see a cohort of patients being labeled as ARVC, hypertrophic cardiomyopathy, and ischemic mimics. One of the things I would like to highlight here is inflammatory conditions generally have a very high prothrombotic risk. So these patients have a higher risk of developing a stroke, and we tend to have a low threshold for anticoagulation in these patients. Let me just illustrate by a case example. This patient presented to us a couple of years ago with refractory heart failure, labeled as dilated cardiomyopathy, and with worsening symptoms of heart failure. She was on optimal medical therapy, maxed out on the doses, admitted twice for heart failure, IV Lasix and dobutamine was given. And the ECG shows a sinus tachycardia with a left bundle branch block. And as you can see, there is a bit of a cardiomegaly on this X-ray. This patient had all features of heart failure and with pulmonary venous congestion. She was actually referred for a therapy called as cardiac resynchronization therapy, which is advised in patients with severe heart failure and left bundle branch block who remain refractory to medical therapy. So by all guideline indication, this patient was indicated for a CRT therapy. And you can see the LV barely moving, mitral regurgitation, and you can see in short axis, I hope this plays. Okay. Very poor LV function and a rocking movement of a left bundle branch block. Now, to cut the long story short, we evaluated. Patient had a palpable lymph node in the neck that increases your threshold for diagnosing this, considering this disease. And when we did a PET, we found intense uptake in the left ventricle, multiple nodes in the mediastinum, biopsy of which showed a non-caseating granuloma, all confirming a diagnosis of sarcoid. Over the next 6 months, she was treated with steroids and methotrexate. You can see a progressive decline in the left ventricular size, progressive improvement in the EF, and a progressive reduction in mitral regurgitation. Lo and behold, the left bundle branch block disappeared and the QRS normalized, and there was no more an indication for a CRT for this. It's an expensive therapy. This was not needed for this lady because a correct diagnosis of inflammatory cardiomyopathy was done. And this is the ejection fraction with a good left ventricular contractility at the end of 6 months. So what are the clinical pointers? Number one is it has been shown that if you have had a past history of tuberculosis, lymph node tuberculosis or pulmonary tuberculosis, these patients are not able to clear the mycobacterial antigen completely, even though they become sputum negative, if the disease is treated. Some of them, the residual mycobacterial antigen can trigger a sarcoid response. Past history of Bell's palsy in a lady who presents to you, recurrent skin nodules, sometimes it's like an eczema, psoriatic nodules, and you don't get a sudden onset of asthma at 50 years of age. When you have an adult onset asthma, this disease needs to be considered because they can present with both obstructive, restrictive airway disease with pulmonary vascular disease. And recurrent uveitis can present with redness of eyes frequently. And this is a typical picture in these patients. So there are a lot of variations. You should kind of have a very high index of suspicion when you have a soft tissue swelling like a pinna being very hypertrophied, dactylitis, typical rhinophyma that you see as a reddish swelling over the nose, cystic lesions, this myositis that you see. A person who has a stable tattoo or a scar for many years, suddenly when there is sarcoid, these tattoos become very hyperpigmented and hypertrophic. Those are all indicators for you to suspect sarcoid. I don't know whether an ECG was presented. One of the distinct signs is a QRS fractionation. Within the QRS, there will be notches. When you see that, you should suspect that there is a myocardial disease. It's not specific for sarcoid. It can happen in cardiomyopathy or other conditions. But it's not a benign idiopathic PVC. You need to investigate this patient for further. This is what I mentioned. When you have distinct morphology, in contrast to a VT, which has the same morphology beat to beat to beat, you feel 2 distinct or 3 distinct morphologies running in the same strip should make you suspect that this is a myocardial inflammation. Approximately 20% of our patients have active myocardial tuberculosis, which is proven by histopathology and the culture, where this is a very close mimic for sarcoid. that should always be excluded in our cohort of patients. I did present a success story where we treated a patient with sarcoid and patient became better. This is an unfortunate lady who came to us in 2012 for a pacemaker. She was about 45 years of age, presented with unexplained AV block. And we did tell this lady that she needs further evaluation. Like most of our patients, she had a relative in the US who strongly said, just get a pacemaker and get out of the hospital. And therefore, we were obliged to put a pacemaker. And a couple of months later, she started having LV dysfunction and episodes of VT. And then at that stage, she consented for a biopsy. Lymph node biopsy was done when the sarcoid disease almost was burnt out. You can draw a parallel to tuberculosis. You see an active pulmonary tuberculosis versus a person with a destroyed lung. It is at that stage they develop a lot of symptoms. We offered her a CRTD and she had progressive heart failure and ultimately succumbed despite all these expensive therapies because the diagnosis was delayed. So I would like to emphasize whenever you have a person with atypical symptoms, cutaneous manifestation and pulmonary manifestation, you should consider that the patient may have myocardial inflammation. It is not always tuberculosis. In our part of the country, about 20 to 25% of them we have myocardial tuberculosis. And ACE levels are notoriously insensitive for diagnosing sarcoid. In our experience, it's less than 10% is the sensitivity. The diagnosis is very important because disease-specific therapy with immunosuppression literally prevents them from going on to progressive form of cardiomyopathy and heart transplant. I'll end there and thank you for the patient listening. Thank you.
Thank you very much, sir. In fact, it was a very clear and a crisp presentation of what exactly the audience need to know. Thank you so much. Dr. Malini, would you like to go ahead with the next slide?
Yes, sir.
Yeah, next slide. Next slide. Yeah, we have finished the discussion break. Yes, please go ahead now.
Just to recap, in early 2022, this couple have come for a pre-pregnancy counseling. They were counseled by the multidisciplinary team involving the rheumatologist, the cardiologist, and of course the maternal fetal medicine team. So during this pre-pregnancy counseling, the disease activity was reviewed. So she was asymptomatic for the past 1 year. The serum ACE levels were normal. ECG was showing a normal sinus rhythm. 2D echo was showing a normal functioning heart. PET CT showed total metabolic resolution and the 7-day Holter study was normal. So the medications were reviewed. She is on azathioprine, HCQS. Metoprolol was stopped as there was no recurrence of VT in the past 2 years. And steroids were also tapered and stopped as her fasting sugars were high and the disease is very well controlled. She started on ecosprin 75 milligrams once daily. So here, as she is contemplating pregnancy, the effect of pregnancy on sarcoidosis and the sarcoidosis on pregnancy were discussed. And she is asked to monitor her pulse at home to be on since we terminated these steroid and other therapies to look for any recurrence of ventricular tachyarrhythmias. And she is advised to go ahead and plan pregnancy. And the plan was to add metoprolol after the first trimester.
Thank you, Dr. Malini. At this point, we'll take a small break. Now the team from Fernandez Hospital who manage the patient are here along with Dr. Malini. We have Dr. Tara, the obstetrician, and Dr. Manokan, the anesthetist. Maybe they can also answer the question I will ask the obstetrician will be that, Dr. Tara, if you're there, you can answer. What are the important details that you discussed during pre-pregnancy counseling in this patient? What were the red flags you will be looking for in this patient? Dr. Tara, are you there?
Yeah, I'm there. Good evening, everyone. Sorry, I'm just recovering from this throat infection. Thank you for the opportunity. Being a high-risk referral center, when the women come for pre-pregnancy counseling, The most important factor is we just don't finish counseling in one session. First, we would like to hear what the problems they had and how the diagnosis was made. And then we will review the literature, because even for me, for the first time sitting in outpatient clinic under sarcoidosis and pregnancy, I just don't offer the first time the counseling part of it. But most importantly, these days, I find the comorbid conditions associated with the present medical problem, like obesity, diabetes, significant family history. And this lady actually had a bilateral ovarian cyst removed, and that was a mature cystic teratomas. So she may be having fertility issues. So the first thing is comorbid conditions, the present diagnosis, how was it made, and we will take time to review all the papers. And then we would like to involve the rheumatologist actually who has first made the diagnosis. And then along with our team, because we formed a small team of obstetric medicine along with the physician, the anesthesia, and the maternal fetal medicine team, we sit together and form a plan, like what is that we are going to look at and what does the literature support us. The first thing I learned over the 20 years is first understand the problem, read the literature, because we don't get the knowledge immediately for such
I think,
cases like cardiac
Tara, you're making a
sarcoidosis.
wonderful point here, a great point. Two important points you made here. One is that it is always a teamwork. A complex case like this, you have a team, and I think all of us should look for to develop a cardio-obstetric team. I think that involve the anesthetist as well. Now, the second important point that she said was we went and reviewed the literature. Many times we have to understand that these kind of diseases we do not know often. We don't have any experience. So instead of just imagining or assuming what will be better and advising it, we can always ask the patient to come again. In the meanwhile, we can go back, take a discussion, consult with colleagues, senior people, and then come back and then counsel the patient. I think thank you so much for making two very valid points. And to the cardiologist, maybe Narasimhan sir and Dr. Deepak, during, what will be how frequently you would like to follow these patients up during the antenatal period? And is there anything in particular you'll be looking for in the drug optimization in these patients? Narasimhan sir, are you there?
Yeah, I'm there. So one thing we should understand is sarcoid is not universally fatal. There is a very benign variant. That's what makes it a difficult disease. For example, persons with low grade, some of them with uveitis disease, some of them with isolated lymph node disease in the mediastinum can go on without symptoms for many years. On the other hand, there is a malignant form of sarcoid which kind of goes on with remission and relapses. So going through the history tells you that what is the phenotype you're likely to see. So if you have a phenotype with cardiac involvement, pulmonary involvement, and markers are elevated, this patient is going to have remission and relapses. Second is, if you have a person, there are persons with familial sarcoid. That's a disease conferred by certain HLA phenotypes. They have high tendency for remissions and relapses. Third is what was brought out in this patient. We are now seeing a subset of patients. Sarcoid is the first manifestation of an occult malignancy. Tumor antigens can cause sarcoid-like reaction, and it's called a sarcoidoid granuloma. Typically, it is more often seen in B-cell tumors as well as in thyroid malignancies. And a different form of malignancies, tumor antigens can sometimes create a granulomatous reaction. So you shouldn't be barking at the wrong tree. If a patient has weight loss and other features, you need to investigate the person for occult malignancy.
Thank you, sir. There is one more question in the audience. I'd be happy if Narasimhan sir, you can give the answer. Should we suspect sarcoidosis in all patients of AV block, irrespective of the age of the patients? Or when should we suspect sarcoid in a patient with an AV block?
So the question is, it's a difficult question to answer, but let me try. Deepak, you can pitch in. normally just like you see cataract in elderly, as if you see vascular calcification, that's because of calcification AV block happens because it encroaches the conduction system. So elderly person above 65 years of age with comorbidities like hypertension, diabetes comes to you with AV block, we are not likely to investigate for sarcoid because the yield is likely to be quite low. On the other hand, if you have it in a very young person, most likely it's congenital AV block, we don't investigate. But if you have a middle-aged person without risk factors, no prior surgery, no drugs, no other reason for having an AV block, then the yield is as high as 30% of them have an underlying granuloma. Some of them may be idiopathic. Some of them may have genetic cardiomyopathies, or they can have this kind of myocarditis presenting as not necessarily sarcoid. It can be tuberculosis.
Thank you, sir. Thank you very much. We'll go to the next slide. Dr. Malini, can you go ahead with the obstetric course antenatal period, and then we'll take the next break after that?
Yes, sir. So she was booked with us at 12 weeks of gestation. At booking, her BMI was 26 kilogram per meter square. The baseline maternal investigations were normal, and she remained asymptomatic in terms of her cardiac symptoms. Her excess tolerance at that time was 2 floors. She could comfortably climb 2 floors of stairs. And as it was previously planned, we restarted metoprolol 25 milligrams once daily after the first trimester. So her family history, surgical, social history, they were all nil significant, and she was very well adjusted to her early pregnancy symptoms. So even before she came to us, she was even before she booked with us at 10 weeks, she again went to the cardiologist, the rheumatologist, and an ECG, echo, and 3-day patch Holter. All of them were normal. The rheumatologist also advised to continue the same medications and asked her to review in the second trimester. So currently she is on HCQS 200 milligrams once daily, azathioprine 50 milligrams twice daily, and metoprolol 25 milligrams once daily. So throughout her antenatal period, she was under the multidisciplinary team care as detailed by Dr. Tara. So she remained asymptomatic. She was found to be anemic in the early second trimester, and anemia was treated aggressively. Thyroxine supplementation was done to treat the hypothyroid. She was diagnosed to have gestational diabetes, and it was corrected with medical nutritional therapy. And she remained euglycemic throughout her pregnancy. And the monitoring of the fetus, as she was on the beta blockers, it showed an appropriately grown fetus for the gestational age. And we had a multidisciplinary team consults at 10 weeks, 28 weeks, and as well as 36 weeks. And critical care and anesthesia team reviews were done at 32 and 37 weeks. And we had a delivery plan in place for her, even when she came to us, even in the chance that she came to us in an emergency.
So you can launch poll 3. Medgamy team, you can launch the poll 3 now. Audience, I think there is already a question in the question chat box. You can answer here, the person who asked the question. I think Dr. Anil Kumar kindly answer here as well. We'll discuss your poll here, question in this poll. The following drugs cannot be used in pregnancy to treat. Methotrexate cannot be used, amiodarone, leflunomide, they have the greater votes. It's a multiple choice answer for you. Maybe another 5 seconds, we'll wait. I request the audience to cast your vote, because this gives us an idea as to what to discuss more during the discussion time. I'll get the inputs from Dr. Narasimhan, Dr. Deepak, and the obstetric team and the Fernandez hospital team. Okay, you can show the results. So maybe I'll ask a question here. So what do you think about this poll answer, sir? Narasimhan, sir, would you like to discuss here? Then after that, I'll ask the Dr. Malini and team to discuss.
Yeah, the thing is, this is a difficult, you would like to avoid most of the drugs. Amiodarone strictly no in this patient. Beta blockers, we can try to use some of the lipophilic beta blockers you can probably use if it's indicated. If you're really pushed against the wall, one of the drugs we use in pregnancy is sotalol. Ventricular arrhythmias responds well to sotalol. So you can up-titrate the sotalol. Pregnant women tolerate it much better. You need to watch out for the fetal bradycardia in these patients. And among the immunosuppression, the safest drug is probably only azathioprine. I don't know the answer to the question whether it is safe in first trimester. I don't know the answer to the question.
And Dr. Malini, thank you, sir. Thank you very much. Dr. Malini, Dr. Betsy, can you give your comments here? Anything other than what Dr. Narasimhan has said?
Actually, methotrexate, if the patient is on methotrexate, we have to stop because it will take almost 4 to 6 weeks for it to get washed off completely. So anyway, as sir said, it has to be stopped and we have to start on high dose folic acid also. Usually we give 400 microgram as prophylaxis when they're preparing for pregnancy. So here, since it is an anti-folate drug, we'll have to give almost 5 milligram. This leflunomide animal studies have shown strong teratogenicity. Human studies are awaited. So for the time being, it is contraindicated. Amiodarone is a class D drug. As sir rightly pointed out, it is also contraindicated. Beta blockers, as in this patient, she was on metoprolol. It's okay. Azathioprine, we have got lot of evidence from other autoimmune diseases. We continue during pregnancy, and deflazacort also as a disease modifying agent that also can be continued during pregnancy.
So thank
So
you.
the answers will be right. The opinion of the audience is very right. They have voted for methotrexate, amiodarone, and leflunomide of more than 55%. Answers are right.
And what is your comment on azathioprine HCQS in the first trimester? Dr. Anil Kumar.
No issues, sir. We continue. We do continue in all other autoimmune diseases. So also in sarcoidosis. No harm.
Okay. The other question that I would ask you is sometimes, when the patient comes to us pregnant with these drugs already on board, or they want to become pregnant, have you given any resins or something to wash these drugs off?
They talk about cholestyramine washout and all, especially for leflunomide. That's what you asked, sir? If they are already on the drug.
You're right.
Yes, it is all or none phenomenon. Actually, before the period of organogenesis, if they have been on the drug, it's mostly all or none. Either the fetus is affected or not affected. So we don't advise MTP just because they had been on this drug, but stop immediately. We stop and then switch over.
Okay. Can we, Dr. Deepak, you would like to comment anything? We can move to the next poll if not.
The only thing that I would like to add on is these biologics that are sometimes used, especially if you're dealing with any amount of flare-ups during pregnancy. Again, very rare, but this can actually happen, or you make the diagnosis first time in pregnancy itself. Biologics are also safe, but with the caveat that in the postpartum period, when you give vaccines to the children, you've got to be careful. If it's actually crossed the placenta and gone in there, you might not be able to kind of, you give the vaccine completely.
Thank you, Dr. Deepak. Can you launch the next poll? Delivery plan, I think. What is the next poll? Yeah. What is the recommended approach to delivery plan with the women with a significant sarcoidosis and known tachyarrhythmia? Known arrhythmia. Again, this is not an easy, straightforward question. We need to give multiple discussions maybe. Okay, most of them I think have it's equipoise between elective LSCS and vaginal delivery, and some of them cesarean only in case of cardiac arrhythmia episodes. I think all could be right. Yeah, we'll stop the poll and show the results, and then I'll ask the obstetrician, what would be your mode of delivery plan in this patient? Either Dr. Malini or Betsy, you can answer.
I
Dr.
think this time the audience have got it wrong, because most of the times people are confused between cesarean and vaginal delivery. This shows not only in sarcoidosis, many of the times, especially in high risk people like many of the hospitals go for elective cesarean, but actually speaking, in sarcoidosis, especially this patient, she's in remission. She had had a good antenatal period, no flare up. And sarcoidosis, as I mentioned earlier, it's with remission during pregnancy. Just like any other antenatal woman, cesarean is only for obstetric indication. Just because she has the disease, we don't have to go for cesarean, but there should be a backup. In case she requires a cesarean, we should have a proper anesthesia and, of course, cardiac backup. So this time, the answer is option 2, vaginal delivery with continuous cardiac monitoring.
Now let me ask Dr. Malini and the Fernandez Hospital team. I think you have some slides on this. You would like to share the slides, Dr. Malini?
Yes, sir. I agree with Dr. Betsy. We will allow for a vaginal delivery, and option C, induction of labor at 37 weeks, is also not indicated. Since she is very well under remission with no flares in pregnancy, we can wait further so that she can set into a spontaneous labor.
Okay, you can show the next slide. Next slide. Yeah, that was your plan. Right.
Yeah, so this is our plan that our team made. We allow for a vaginal delivery. LSCS only for obstetric indication. We plan to induce at 39 weeks if she does not set into spontaneous labor by that time.
Now let me ask the anesthetist team, Doctor. I think Manokant is here. Dr. Manokant, I think you were involved in this patient as an obstetric anesthetist. Can you just let us know what was your plan and why you had this plan?
Yeah. So for us, the main concerns are any presence of basically, like we have been discussing, presence of baseline ejection fraction and heart failure, and how frequent or how severe are the arrhythmias. So luckily for us, in this woman, she was very well optimized. She was in remission, and we didn't have that full plan. But just in case, but still we have to be prepared for any arrhythmias most of in this patient. So our plan was to have close monitoring, continuous ECG monitoring in labor and saturation, and also to have all the equipment basically ready to go to treat any unexpected or sudden arrhythmias. So we had A-line in place for invasive blood pressure monitoring. We planned for early epidural because again that reduces the stress overall, and we had the defibrillator with pads ready. And also steroid like hydrocortisone injection, and then IV beta blockers like metoprolol ready. If that's not enough, then amiodarone ready. Again, we checked for the second line drugs like sotalol, flecainide. So all this we had stocked up and ready. Basically, she doesn't have LV dysfunction, but arrhythmias could still happen. So we were ready. So that was the idea. So we were ready to treat the arrhythmias in case she has any during labor. And that was the main thing.
Thank you, Dr. Manokant. There is one question I think wanted the opinion of the experts. In patients, is there any role of continuing low-dose steroids during pregnancy? What is your thought, Dr. Malini? Did you continue steroids in this patient?
No, sir, we did not continue any steroid. She was totally in remission. She did not have any VT runs for the past almost 1.5 to 2 years. And even the investigations did not show any disease activity, metabolic activity. So she is not on any steroid. She was only on azathioprine.
But is there any role for low-dose steroids in any such patients? If that is the case, is that safe?
Low-dose steroid is safe in pregnancy. It does not have any fetal side effects. But whether it is indicated or not, that would be the call for a rheumatologist and the cardiologist based on her symptoms and investigations.
So maybe to the audience that we can, ask the question. Thank you for your question as such. So we would say that if there is an indication, definitely you can use that. And you can move forward to the next slide.
So with the delivery plan and the anesthesia plan in place, we also had a plan for the postpartum period. We plan to give injection furosemide at 10 milligrams IV 12th hourly for a period of 24 hours in case she may develop symptoms of volume overload. And regular advice regarding the hygiene and healthy diet. Breastfeeding is not contraindicated here, even though she is an azathioprine. It has been proven that azathioprine and HCQS, both of these drugs are safe during lactation. And watch for complications of bleeding, thrombosis, as Dr. Narasimhan was telling, they are at high risk for venous thromboembolism. Thromboprophylaxis, the plan is in place. Antibiotics, as she is on immunosuppressants, azathioprine, so she is at high risk for infection. So she's continued antibiotics for a period of 5 days postpartum. Monitor for wound healing, and she's at risk for osteoporosis. So calcium supplementation to be continued in the postpartum period, and periodic assessment for disease activity to monitor for a postpartum flare. So this was the plan that we had in place for her. So coming back to our case, she did not set into labor spontaneously. We had to induce her at 39 weeks, but because of non-progress of labor, she underwent an emergency cesarean section under graded epidural anesthesia and birthed a 3.2 kg baby boy, active and healthy. Postpartum, she did not have any flares. She's stable, and she's continued on the same medication, that is azathioprine, HCQS, and metoprolol in the postpartum period. And we continued postpartum thromboprophylaxis for 2 weeks, and she's discharged in a stable condition on the 3rd postoperative day.
At this point, thank you, Dr. Malini. I have a question for Dr. Manokant. So now, what are your concerns about anesthetic agency or the mode of anesthesia when a patient who is taken to emergency LSCS after a non-progressive attempt to vaginal delivery?
So, like I've mentioned, main concerns are from cardiac point of view. One is arrhythmias, and second one is failure. So both of the things were under control. The other thing is if there is any tracheal or upper airway involvement, so that during emergency, if she requires a general anesthesia and intubation, so we have to be sure that there's no tracheal stenosis or any tracheal involvement or any difficulty in intubation. So that's one more thing to check from anesthesia point of view and be prepared for such a scenario. So again, luckily for us, she had no issues with her airway. There were no respiratory signs or signs or things to show that there was tracheal stenosis. So that's one part. Second thing is, of course, you don't want any sudden hemodynamic changes. So there are two ways of doing it. Either you do a graded epidural, so where you give small doses of local anesthetic slowly and build up anesthesia over 15 to 20 minutes. Or you can also do a low dose spinal combined with an epidural. So where you will give a very minimal dose of spinal anesthetic, like usually 6 to 7 milligrams. So with that, they will get a adequate motor block, but that won't last longer. You have to top it up with, again, small doses of epidural boluses so that there's no change or sudden fall in hypotension. Again, you have to play catch up and give some vasopressors and things like that. So you want to keep it at baseline as much as possible. So these are our main concerns. And then post-op pain relief. So we usually add a neuraxial morphine, about 100 mics in spinal anesthesia. If we are using epidural, then we give up to 3 milligrams. And then it becomes easier to manage post-operative pain for the first 24 hours. Then you can simply, the additional multimodal pain management with paracetamol and in this case, maybe even diclofenac should be enough. That will provide very good pain relief for them.
Thank you, Dr. Manokant. At this point, maybe let me ask the cardiology team, Narasimhan sir, what do you think should be the role of a cardiologist in this patient during the intrapartum and the postpartum period? What are the things that can flare up in the postpartum?
No, I think only if we are called for help. I think the obstetricians and the anesthesiologists know about this more. When there's a diagnostic or a management difficulty, we can pitch in. I don't think that's a issue. Only thing is, sometimes soon after delivery, you can see a flare-up of the disease and they have recurrent VT. So it's prudent there to pitch in because you can navigate the space and appropriate choice of therapy may be important there. Because when the disease flare-up happens, very often it's the Purkinje fibers that start firing. Or it may be because of myocardial edema. So the timing of the PVC which triggers the VT will help you to choose your drug. If it's a short coupled PVC, we may use quinidine. Whereas if it's a polymorphic VT, we can go up on beta blockers. So class 1A drug helps in certain situations. Monomorphic VT, we may choose class 3 drugs in combination with beta blockers. So it all depends on if the patient is having a very smooth course, I don't think we need to do much unless we are called for help.
Thank you, sir. There's one question from Dr. Vijay Kumar. Can we stop azothioprine for this patient at a future time point? I think you, with your experience, you can answer, sir. You think she can stop azothioprine for this patient?
Yes, I think it's all you need to play it by the ear in terms of what the disease act, because we can't be going on repeating a PET scan. We need certain other indicators to follow up this patient. That's why the ECG is an important kind of, if you see a QT becoming abnormal, if you see something, a red herring on the ECG, which doesn't look nice, you may have to follow it up with a echo. And we tend to use GLS and tissue velocities very closely to monitor these patients. So if a person, you do a PET and the PET shows septum is involved in with myocardial edema, we get a baseline velocities of that area and then follow it, track it down on follow-up. If you find that area is becoming edematous, non-contractile, then you would like to escalate the therapy. We have a very low threshold to do strain rate imaging and follow up these patients.
Thank you, sir. Thank you. There is one more question on steroid. May not be appropriate for this patient, but then for any other patient, Dr. Manil Kumar. Is continuation of steroids, does it not interfere with the fetal lung maturation? In case of a premature labor, what will be the plan of steroid dose before going into the delivery? Maybe the obstetricians can answer.
Yes.
Actually, yes. Continue. Sorry.
Yeah. So the steroids that we are giving here, only the betamethasone and dexamethasone, they cross the placenta and are used for fetal lung maturity. All the other steroids, be it deflazacort, be it prednisolone, they do not cross the placenta. So they are only have the effect on the maternal disease activity. So in case the fetus requires a steroid shot for a fetal lung maturity, then we go with a regular dose of betamethasone 12 milligrams once a day, 2 doses 24 hours apart, or dexamethasone 6 mg every 12th hourly for 4 doses, total a dose of 24 hours. That will not change even if the woman is on oral steroid for some other reason.
Thank you, Dr. Malini. There is one question here, maybe Dr. Deepak, you can answer. Are there any signs that would indicate flare-up other than VT?
Worsening of your ejection fraction, getting tired more sooner than normal, looking at mainly how the patient is doing. If she starts retaining fluid out of proportion to what you would expect her to be. Pregnancy is a condition where you would retain fluid, but if you start retaining fluid to a significantly large extent and not dependent only on the the lower extremities, your face starts swelling up, you would start imagining there is a challenge. There is no good answer because there are two competing physiologic and a pathologic process going on. Teasing them two out is pretty challenging.
Thanks, Dr. Deepak. And then one more question, very unique to Indian scenario. Whatever it may be, the patient always wants to come back pregnant again. So what will be your advice if the patient says, Doctor, I want to become pregnant again? What will be your advice on subsequent pregnancy, both the views of the obstetrician and the cardiologists?
I don't think, as sir said, all sarcoid is malignant. So you would imagine somebody who's had one pregnancy, which is relatively safe, which has gone on smoothly without event. I don't think it's right for us to say, no, don't have any more children. That's probably not the right way to go about it. Yes, there is a slightly higher risk as compared to someone who is otherwise not having sarcoid, but I would not go against it. But if you have any of the red flags, if you had a poor history prior to the first pregnancy itself, somehow you've had a precious baby, those patients, I would probably stop at it.
Yeah, I think that's a very valid point. So, I think the take-home message from this particular aspect is that from both Narasimhan sir and the rest of the team is that pregnancy is very much possible in most women with sarcoidosis with careful planning, monitoring, risk assessment, and team-based management. The pregnancy success and the adverse event rate depends on the disease severity and the organ involvement. So it is very important that we have a preconception disease optimization, like what happened in this patient. They said no pregnancy, then they optimized, the team worked together, and they modified the disease medications in such a way that they're safe for the fetus and safe for the mother, that was safe, and they went ahead with the pregnancy. This thing is very, very important for us to know. So similarly, subsequent pregnancy is not going to be this difficult in if the same original pregnancy conditions are met. It is not like pregnancy in a patient, the peripartum cardiomyopathy, or subsequent pregnancy. We hesitate if there is a mild residual LV dysfunction where there could be worsening of LV function during pregnancy. So now, Dr. Maybe I'll ask Dr. Deepak to share a short presentation on cardiac sarcoidosis during pregnancy. Meanwhile, any more questions? I think there are more questions. After Deepak's presentation, we'll attend the questions.
Let me just summarize this for the benefit of all of us. Is essentially that cardiac sarcoid is a condition where you can have life-threatening arrhythmias, both in the form of bradycardia and bradyarrhythmias and tachyarrhythmias, can result in sudden maternal and fetal death. Syncope is a presentation that should not be left aside and just said, oh, she had a simple faint. Manifestation of these arrhythmias can either be in the form of bradycardia. Bradycardia, not necessarily AV block, but fresh onset development of a bundle branch block that was previously not present. Then again, tachycardia itself in the form of both non-outflow tract tachycardias or non-outflow tract PVC is very critical. This is a very unique case where it's an outflow tract PVC that triggered off the suspicion, but non-outflow tract PVCs are more challenging, more suspicious of the involvement of the conduction system. Then non-sustained VT, pleomorphic PVCs, and rarely monomorphic VT itself. Then when you develop heart failure as such, fresh onset heart failure in a patient with in a patient who is pregnant, then it's very critical for us to differentiate it from postpartum or peripartum cardiomyopathy. It is the ECG changes, it is the presence of the activity, perhaps enzymatic diagnosis, which will actually give us an answer. The diagnosis remains challenging. ACE levels are fairly unreliable for diagnosing onset of sarcoid in pregnancy, as well as chest X-ray and MRI, relatively safe if needed, very, very specific if needed, and preferably not in the first trimester. Going on from there, let's look at pregnancy in pre-existing sarcoid. It's been very well discussed right now or today. There is no effect, or it actually improves the course of pre-existing sarcoid. Essentially, due to the suppression of the Th1 cytokine expression profile, switch over to the Th2 expression profile does age in this disease. Adverse outcomes of pregnancy include preeclampsia, IUGR, preterm delivery for these patients. Multidisciplinary care is definitely needed. Corticosteroids can be given with the understanding that fetal cleft palate actually increases with the use of corticosteroids in pregnancy. Azathioprine is safe in all trimesters of pregnancy. Biologics can be used, but fetal postpartum infant vaccination care is very critical to kind of figure out how you want to do that. Methotrexate and mycophenolate mofetil are definite no-nos in this case. And perhaps, given that there is a high chance of thromboembolism, aspirin may be considered at 12 weeks to begin with. Folic acid supplementation in patients who've been on methotrexate are also very important. In the close to delivery period, what is important is to actually check up the forced vital capacity for these patients, especially in patients with higher involvement of the non-cardiac locations, especially the lungs. If there is vascular if there's interstitial involvement, the FVC of 1 to 1.5 will actually help in deciding care, yes or no, induce or not induce. And then finally, what worries is the postnatal flare-up, where we have to actually be very careful once the immunity starts changing profiles, be careful and differentiating from peripartum cardiomyopathy. And post-delivery conception planning, as we mentioned, is not something that is to mean that let's stop a woman getting pregnant the next time. Actually figure out what were the red flags before and then go on from there. Thank you once again for allowing me to present.
So thank you, Dr. Deepak. There are a couple of questions, I think, in the chat box. Should we add steroids in this postpartum period in this patient, as there is a tendency to flare up in the postpartum period? What is your comment on that? Maybe one of the panelists can answer. Should we add steroids as there is a tendency for the sarcoid to flare up in the postpartum? Will it help to prevent a flare? Does it have a prophylactic role?
So
There is...
the honest question is, we don't know. For these things, each one of us will have an impression. So I think this is all a clinical decision, because for example, when you do a randomized trial, the risk of giving a steroid versus the benefit that comes from a very rare possibility of a steroid flare-up. So if you, as I said before, if a patient has got a long-standing history with frequent flare-ups, I would probably give a low dose of steroid and wait and watch. But if it's one of, like this patient had 1 or 2 episodes of isolated cardiac sarcoid without any other organ involvement, I would probably not give steroid. But having said that, there is no right or wrong answer about that. But more importantly, one of the things we have noticed is we become so specialized that we lose the whole picture. These patients in any post-operative state or even post-delivery, for example, if the patient develops delirium, if the patient develops a little bit of dimness of vision, one of the worst complications of sarcoid is neurosarcoidosis. You need to have a very low threshold for picking up neurosarcoid. So very often we think is ICU delirium, post-operative delirium, patient is having steroid toxicity. These are all common misdiagnoses we have seen when a patient comes actually with neurosarcoid. Typically, like COVID, they come with loss of smell. They can come with palsies, facial palsies, pituitary disease, headaches and vomiting, delirium. So the slightest suspicion, if this patient has neurological symptom, that is more important to kind of pick up and treat. And it's a lot more challenging.
Thank you, sir. 2 more questions I think we'll answer in the chat box. In the interest of time, I think we should close. Except maybe I'll just show one nice slide sent by Dr. Annie here. As you can see that this in the management of sarcoid, you really need to have maybe this can be a last slide, and we need an expert multidisciplinary team. In the preconception counseling, as you see, this patient is very nicely planned. What can be given, what investigations can be done in the antenatal period. I think maybe some of you can take a snapshot of the slide. This does have a lot of information here. And the patient, the timing of delivery, all that we had discussed here. And so we had a great time, a good time of discussion, and a lot of questions were asked, and questions are continuing to come. But as we had planned up to 9 o'clock, beyond that, we'll definitely answer these questions. And to all of you, would like to share with you that all these questions, the answers given by the specialists will be collected and pulled together as a small newsletter and will be circulated very soon in the groups where you had the communications. So we had a great case, thanks to Fernandez Hospital team, Dr. Malini, Dr. Tara, and Dr. Manokant, and all your colleagues for having agreed to share this presentation. It was so much of learning and teaching for each and every one of us. And Narasimhan sir, I think you had a very crisp and a very useful lecture, and all along you had been the pillar of giving inputs. It was so nice to have inputs coming from a person like you who have been working practically, so much on sarcoid. Thank you so much for your presence. I know that you adjust your flight timings to join this. Thank you so much. We really
you.
appreciate that. And Dr. Deepak, thank you so much for pitching in and joining. And Dr. Annie, thank you very much for coordinating everything. Dr. Betsy, thank you so much. Dr. Betsy is principal investigator for National Pregnancy and Cardiac Study from Amala Institute, Thrissur. Thank you for your interest. And thank you, Medgami team. And above all, most importantly, I would like to say that the audience questions have been phenomenal. And you have almost asked 14, 15 questions. And all questions have been answered except two, which will be answered in the I think one has been already answered. Like, I think all the questions have been answered live. Yeah, good. So thank you so much for your time, and thank you, Team Medgami, and thank you, audience. And please, join us for the next 8th Cardio-Obstetrics Master Class. That will be in the month of April. We also look for you to Google Cardio-Obstetrics in the YouTube and subscribe to the channel where these things will come as a video. We also have a social media group called Cardio-Obstetrics, where we'll be discussing only cases related to cardio-obstetrics and nothing else. So if you're a person who would like to join, please do let us know. We'll add you to the group. And thank you very much. And with this, I think we want more and more cardio-obstetric groups to be formed and societies to be formed so that women with the heart disease going through pregnancy will have a safe motherhood and they will have the joy of being a mother in our country. Thank you so much for your time. And with that, we close the webinar. Thank you very much, Team Medgami.